Hello, this is a quick primer about stroke. So the best way to think about stroke don't think of it as stroke, think of it as vascular neurology, in that it is a sudden onset neurological symptoms that are usually of maximal deficit at onset, and they respect vascular territory. It needs to be biologically plausible that these symptoms are all in the territory of one set of blood vessels. Also, thinking about vascular helps you classify things, so you can think of it in terms of the size of the vessel. Is it a tiny blood vessel that's blocked, or is it a large one? And also the number of blood vessels, so whether it's multiple emboli, which makes you start thinking about cardioembolic. Also, if we think of it in terms of vascular disease, it automatically gives you the risk factors, the usual risk factors for vascular disease. And likewise, if it's cardioembolic, you can think about things that might make the heart predisposed to clot formation, AF, if you've got nasty endocarditis, or if you've got an akinetic sluggish LV that can create clots. So in practice, let's think about what you might actually need to do for these patients. Well, first thing, a CT brain is the chest X-ray of neurology, and an acute CT or a rapid CT for a suspected acute stroke is really useful. What you want it to show is nothing at all, but it might show a bleed, or it might show a dense MCA. There we are, dense MCA there, or it might show some early ischemia, and maybe that looks a bit less dense than that, so can be very useful, and it's there to rule out major bleeds, or suspicion of a tumour, or hydrocephalus, which we had yesterday. MRI is what you want to do then for kind of everyone. So actually it's easier to talk about the people who don't need an MRI, and actually you don't need an MRI if you're entirely confident that clinically this is a stroke, you know the territory that's involved, and you don't think it's cardioembolic, and really it's not desperately going to alter management. Carotids you need if you think that it's carotid territory. It's slightly difficult because about 1 in 5 people have actually got a persistent fetal posterior communicating artery. In other words, there's a connection between their anterior circulation and their posterior circulation, so it's kind of tricky. So there's justification for doing carotids in everyone, provided they are a candidate for an endarterectomy. So this is all to look at carotid atherosclerosis, and it's a referral to vascular and refer a patient if they've got a nasty looking carotid. Whilst we're on carotids, it's not just atherosclerotic disease. You can also get carotid artery dissection, and indeed vertebral artery dissection. These are relatively common in younger patients. The younger the patient, the more likely it is to be a vertebral artery dissection. Almost invariably you get pain in the neck as well, and that pain can be any time in the preceding few weeks. So sometimes they get the pain and then of the dissection, and then the false lumen takes a while to form, and the nasty blood clots can come out at a later date. So watch out for the preceding ones. CTA usually shows it really well. In fact, usually it is possible, but it's vanishingly unlikely that a CTA will miss a dissection. Echoes. We're meant to get echoes on everybody. Actually, in older patients, they're very rarely of any use. The main indication there is really endocarditis, though they can be quite useful for thinking about LV thrombus if someone's got really bad heart failure. They are really useful in younger patients. And again, the younger somebody is, the more likely they might have something odd like a cardiac tumour, or an LV thrombus with unsuspected ischemic heart disease or structural heart disease. And endocarditis is always a worry. It can be difficult. Duke criteria, that's a useful thing. Stroke bloods, there are stroke bloods on the system, and there's young stroke bloods, and that's generally looking at whether or not someone's got a vasculitis or antiphospholipid. Have they got undiagnosed primary hypertension? Have they got a coagulopathy? Almost invariably not. And is there organ disease elsewhere that's predisposing you to atherosclerosis, or generally being a bit crook? And obviously fasting lipids, terribly useful, and we should be certainly emphasis on trying to look for hypertriglyceridemia, possibly more than we do. So thinking back to the idea of vascular neurology, it is, I mean, this isn't an actual stroke. This is somebody drawing some grey area on a picture of a brain. But if you get a proximal MCA occlusion, you get a large area of the MCA involved, and for that you're going to get cortical signs. Now we look for things like aphasia or dysphasia, because that's something that's easy to pick up at the bedside, but really what you're looking for is any dysfunction which is done by the cortex. So hemianopia, because that's your visual cortex, and it's not just the visual cortex, it is the optic radiation. So your optic radiation, lateral geniculate ganglion or nucleus, which is in your thalamus, and then your optic radiations then go back from there. So anything in this sort of area will give you a potential visual field deficit. So from this scan here, LGN optic radiation is going to be coming through here. So in this temporal lobe infarct here, you could potentially be getting actually probably a superior quadrantenopia if it was just that, because the visual fields are upside down as well. But the point is, you're thinking of a big stroke if you're picking up cortical signs. So you can get more distal events in an MCA, and if you get a little clot up here and you just get a little wedge-shaped infarct just here, this can give you something isolated. So you might just get a single limb that's involved, or maybe just a bit of dysphasia, or maybe just a bit of, if it's in the parietal area, maybe just a little bit of apraxia. So, and these are often sort of quite interesting, these ones. And this is like a little distal clot, and again, could be atherosclerotic, could be a single cardiac embolus. And here's one we've heard earlier. This was somebody last summer who presented with a pure dysphasia, pure expressive dysphasia. Just found they weren't as fluent as they would like to be, came on suddenly, it was a stroke, and what do you know? There we are, Broca's area, infarcted. Beautiful. The other end of the scale is there are these perforators coming off the MCA, and these are quite prone to hypertensive disease. So these tend to be older patients with their lacuna strokes, and it's because these perforators can get very fragile and stiff with hypertension over decades, and you just get a little thrombus, in situ thrombus this time, and you get a lacuna stroke. Now, a lacuna stroke, here's the next slide. A lacuna stroke might be small, but the problem is if you get a lacuna stroke just here, for example, it can be quite small, but it's taken out all the flow from there. So although it's not a cortical stroke, it is affecting all that cortical activity from getting downstairs to where it needs to be. So you can have profound paralysis from a lacuna stroke. What you won't have with a lacuna stroke is cortical signs. So speech, you can have slurred speech, but language formation, inattention, visual fields, they're okay. It's purely that motor or sensory outflow from the cortex that's affected. So lacuna stroke, tiny little stroke, can be completely paralysed, but no cortical features. Again, you can pick it up at the bedside. Useful, very, very useful concept. That's another slide saying the same thing. No cortical signs. There's Joe Biden. He's laughing at the idea of you picking up cortical signs in a lacuna stroke. He does that. Strokes in funny places. Thalamic strokes are weird because there's so many nuclei in the thalamus, so they can be a tight. So on the scan, you might see quite a small stroke, but it's in the thalamus, so you can get proper good going dysphasia. You can be confused. You can actually get real cognitive problems. It's usually a sensory stroke, but you can get motor issues, and you can get visual field issues as well if it picks out the lateral geniculate ganglion. So they're strange, and they always need following up because they can get some nasty allodynia and strange pain syndromes. Brainstem strokes always freak people out, but actually they're pretty straightforward because, again, it's packed full of nuclei. Commonest one is lateral medullary. Other brainstem strokes are available. The hallmark is dizziness plus facial pain and your eyes looking funny. Of note, it doesn't involve the pyramidal tract, so you can have ataxia or clumsiness. You're not weak. And your eyes go funny as well. And again, in practice, they're pretty obvious when you pick them up, if you've actually had a little look at the cranial nerves. So that's sort of strokes. In terms, in practice, of how people with strokes behave on the ward, well, they're weak and they take a little while to recover. Seizures are not uncommon, especially in the first week, up to about 10% of people. So, and in practice, you won't see any for a while, and then you'll find everyone seizes 1 week. They're common enough. No evidence for any particular anticonvulsant for post-stroke seizures. There's some evidence for Keppra and phenytoin, none of which reaches significance. In practice, you use Keppra. The problem with Keppra is quite sedating and high dose, so you try and limit the dose, and also you try and stop it as soon as possible once the brain is less irritated. The neurosurgeons love giving people prophylactic anticonvulsants. There is no evidence that that does anyone any good and probably does people harm, so you don't stick in the anticonvulsants until someone has convulsed. Oh, I haven't mentioned, I'm going to go, oh, I can't go back. Status, you treat as a medical emergency like you would any other status. The main thing about status epilepticus is do not spare the lorazepam. Lorazepam is the treatment of choice for status epilepticus, and the biggest problem is people not giving enough lorazepam. You need 4 milligrams of lorazepam in anyone of any size to stop status epilepticus, and you may well need more. Imaging. So, all acute strokes now, we get CT. So this is someone who's in the throes of having an acute stroke. This was someone from the other day. And you get an acute CT head and a CT angiogram. And on the CT angiograms, you will find these things. I don't know if that's going to project, but that is the 30 mil thick slices, and they're beautiful. And in this case, so you can instantly see this person has got an MCA which stops just here. They've got an LVO, a large vessel obstruction, and actually if you look at their plain CT head, there is an insular ribbon just there. You can see it nice and bright on the insular ribbon. There he is, zigzaggy. But on this side, there's a bit of zigzag, white zigzag there, but it's gone black there. It's mushy. There's early ischemia there, as you would expect from the early clot. And then now and again you can see a dense MCA sign there as well. Very useful. If they've got that, provided their modified Rankin score is 2 or below, in other words, as long as they are self-caring, they get a free ride in an ambulance over to Southmead for mechanical thrombectomy. Oh, I've done it there. There we are. Rung there with animations and an arrow also showing the acute ischemia. There we are. Compare the insular ribbons. And there's an arrow showing the LVO. Lovely. So, who can you thrombolyse? You can thrombolyse anyone who doesn't have a bleed. Here's someone with a dense MCA. Here's someone who you can't necessarily see a dense MCA, but they've got early changes. There's the early changes. Not so here. Now we've got over 2/3 of the MCA territory already involved. They are not for thrombolysis. Thrombolysis will cause all that mushy ischemic brain to bleed hideously. And bleeds, you would think twice about thrombolysing, and maybe infinite number of times. The imaging pattern is really useful on scans. This is where MR comes in. So if you're getting multiple strokes on both sides, this is something that is south of the aortic arch. So AF, prothrombotic states such as malignancy, endocarditis, LV thrombus maybe, but this is not in situ disease and it's not carotids. It could be bilateral carotids, but that's very unusual. It's all in one hemisphere. You can certainly then think about the culprit carotid, and you certainly need to image the carotid. Sometimes it's someone who doesn't have an unstable plaque but just has a bit of stenosis there, and they've become hypotensive, drop perfusion pressure, and have failed to perfuse areas of the brain, and you get a sort of slightly watershedy pattern. We've now got CT perfusion, and CT perfusion is useful in terms of selecting who is a good candidate for thrombectomy. In practice, normally if you see a large vessel obstruction, you just ship them over, but if it's a delayed presentation, you can do a CT perfusion scan, which is 30 low-dose CT angiograms, all done in quick succession, and it can identify the penumbra, it's in green there, and the core infarct. The idea is that there's an area which is infarcted and unsalvageable, but there's another area which is just hanging on due to collateral circulation, but is at risk if there's a further drop in pressure in the occluded artery, and will be improved with thrombectomy or thrombolysis. Let's see. Blank slide. Okay, what do you do about stroke? Well, there's primary prevention and secondary prevention. On the ward, people will constantly ask you about blood pressure. In practice, after a hemorrhagic stroke, blood pressure is crucial, he says. There's actually no hard and fast evidence for any of it, but in hemorrhagic stroke, the direction of travel is definitely that for the first week after a bleed, you do need to be getting your blood pressure down to 140 systolic. If this requires getting an NG down, get the NG down. You can use intravenous labetalol, which is actually surprisingly well tolerated, or a GTN infusion. After ischemic stroke, there's no strong evidence that actually it's desperately useful. In fact, if anything, post thrombolysis, you kind of want quite a good head of pressure to help perfusion. Statins, everyone needs a statin. Statins are the good guys. The thing about a statin is that you will get active plaque regression. Here's some slides of a carotid whereby they've got a nasty looking plaque, a nasty lunch, a nasty plaque here that over the years you can, with serial imaging, actually looks a bit worse the year after, but you will actually get regression. People need statins. They're the good guys. They're not allowed to say they don't want a statin. They have to have a statin. Get their cholesterol below 4. Antiplatelets, aspirin and clopidogrel. So aspirin and clopidogrel for a dual antiplatelet strategy is better, but in people who are liable to bleeds, and those people who've got really horrible looking small vessel disease and are refractory hypertension, you may want to go back to a single agent. And larger strokes also are more risky. So you use them for the smaller strokes, high risk TIAs and high risk carotid disease. If you've got AF, you need to be anticoagulated. Watch out for dose adjustment when it comes to people with poor renal function or who are very light. There's very few contraindications to starting anticoagulation in someone who has got AF. Be guided by the CHA2DS2-VASc. If they've got a really high falls risk, then if the CHA2DS2-VASc is high, they still need it. If the CHA2DS2-VASc is, or if the CHA2DS2-VASc is reasonably low, you might be justified in not giving them anticoagulation.